a new therapy was approved for acute ischemic stroke, and it was a clot buster medicine, which was approved initially for up to 3 hours. Then later ECAS-3 trial extended this window up to 4.5 hours, and now we can apply this medicine up to 9 hours in some selected patients. In multiple trials, it has been shown to be equally effective as Alteplase, and it has the advantage of having a prolonged half-life, a slower plasma clearance, facilitating its administration as a bolus dose. It is very easy to administer. It is very suitable for inter-hospital transfer or pre-hospital thrombolysis. It has higher fibrin specificity, and theoretically it has a greater rate of recanalization, and in trials it has been proven to be superior than Alteplase in LVO scenarios. So there are multiple evidence favoring Tenecteplase, and in recent guidelines it has been recommended as an alternate to Alteplase. Our own study have revealed that this agent, we have worked with Tenecteplase 20, and we have shown that it is equally effective and it is non-inferior to Alteplase in our scenario. We have conducted this multicentric study in 6 hospitals of West Bengal. However, till now, the access to thrombolysis and thrombolysis capable center is poor in our country. And as we can see that there are only 566 thrombolysis capable centers across India, and in spite of having huge number of cases, only 25% of Indians have access to stroke ready hospitals, and number of thrombolysis is low. In our state, during late 2021, under the Sastho Ingit telemedicine program, a TeleStroke program was launched. Initially, it was launched in a pilot mode involving BIN as the hub institute and 12 hospitals as the spoke hospitals. The full-fledged program started from July 2022, and currently it has 40 spoke hospitals and 1 hub, that is our institute. Among these 41 hospitals, 32 hospitals use telemedicine guidance, whereas 9 hospitals have neurologists and their patients undergo treatment under their direct supervision. So till date, since 2022, we have thrombolized 1,454 patients in this program. Here we have created an SOP which can be followed easily in the emergency of any hospital, any resource poor hospital. Whenever a patient arrives with a suspected stroke symptom, first we have to document the time of onset, and if it is within 4.5 hours, the patient has to go for an urgent CT scan using the green sleeve, as Viman sir has shown earlier. And if the CT turns out to be non-hemorrhagic, then the hub must be informed immediately. And if the patient is eligible for thrombolysis, the patient must go thrombolysis. And as we all know, that in our state, the thrombolytic agent is given free of cost. So the denial rate is much lower compared to other parts of the world. And here is a diagram of the entire network, and as you can see that each and every district of West Bengal has now at least 1 thrombolysis capable center. And today, any stroke patient of West Bengal can access a stroke ready hospital well within 3 hours. Why it is important? Why 3 hours is important for us? Because we have our intra-hospital delay, or I would rather say the door to needle time in this program is approximately 80 minutes. So we, if a patient presents within 3 hours, there is higher chance of that patient getting thrombolized if he is eligible. So now we are focusing on a better model to reach out to the community and extend the coverage of this TeleStroke network. It is known as the hub spoke and sub spoke model. We are currently evaluating this new model of TeleStroke service delivery in a project called TestNet project. So the early results during the annual report submission to ICMR, we have found that this model is better than the conventional TeleStroke network, which involves hub and spoke hospitals and doesn't connect the community with it. So we have rather got some encouraging results in our research board setup. Among the thrombolized cases, 1,379 patients have completed 90 days follow-up, and approximately 56% of those patients have achieved functional independence, defined as an MRS score of 0 to 2 within 90 days. And approximately 5% patients had symptomatic ICH, and almost 19% patients had an all-cause mortality within 90 days. So all these parameters are at par with world literature. And in another analysis, we have also shown that the outcome of the patients thrombolized under telemedicine guidance in a resource poor hospital is similar to the outcome of patients who are thrombolized under the direct supervision of a neurologist. So these two are the game changers for us, and we are hoping to extract better results with better models of TeleStroke delivery and measures to reduce pre-hospital delay, so that each and every stroke patient, be it hemorrhagic or ischemic, because in the community at the onset you don't know whether you are having an ischemic stroke or hemorrhagic stroke until and unless you are undergoing a CT scan. So we hope that each and every patient arrives at a thrombolysis capable center within 3 hours, and we are trying to sort out new methods of doing that, be it giving incentive to ASHA. We are doing that in a pilot project. We are evaluating the new hub spoke sub spoke model in a testnet project. So we are trying to improvise our TeleStroke network so that we can extract the full utilization of this. Thank you.